staff and the 9:30 committees to start on time for theirs. Today, I'm pleased to have the 2024 Palliative Care Legislative Priorities that's going to be presented to us. But before we do that, we didn't get to have committee yesterday, so I'm going to give the staff an opportunity just to go around and introduce themselves for some of you who may not know them, and then the same with our committee. And let's just start down there at the end.
My name is Carly Humes with the Revisor's Office. This is my third session and first year staffing health.
Good morning, committee. I'm Jenna Moyer, and this is my 9th session, maybe my 5th or 6th year staffing health. And Scott Abbott left our office this past fall to work for Johnson County, so our health team has switched up a little bit, which is why we added Carly, and Eileen will be here every day in committee.
Good morning, everyone. I'm Eileen Ma from the Office of Revisor of Statutes. This is my 10th session. It's like 70 years in dog years, maybe. And this is, I think, my 8th or 9th year staffing health.
Elizabeth, go ahead.
Go ahead.
Elizabeth Cohn I'm KLRD. I'm a senior research analyst. This is my second year on health.
Fairbanks, committee assistant. This is my 10th year, and I think 6th year on health.
My name is Anthony Valencia. I'm one of the AV techs, and this is my first session.
And then we'll start down here with Senator Stephan.
Mark Stephan, Senate District 34. Thank you.
Good morning. I'm Senator Cindy Holscher, District 8, Overland Park.
Good morning. Renee Erickson, Senate District 30, which is East Wichita.
Senator Petty.
Senator Pat Petty, District 6, Wyandotte County, Johnson County, and a ranking minority on public health.
Senator Chase Blasey, West Wichita and West Sedgwick County.
And Mike Thompson, Senate District 10, Northwest Johnson County.
And we have two of our members who are out today who are on WebEx with us. Thank you all for being here, and thank you for those who are also on just observing on WebEx, and thank you for those that are out here in our audience today. We're going to begin with the 2024 Palliative Care Legislative Priorities. This is an organization that I was pleased to be appointed to serve on their commission and ask them to come and just kind of let our committee sort of know what palliative care is all about. I had chaired this past year the Bob Bethel Committee, and they made a short presentation there, which I thought it would be good for our committee to hear. And are we ready? We're ready, and yes.
Were we going to do bill introduction?
I apologize. Yes, I did not have that on that list. I had it for yesterday, but then we weren't able to have committee yesterday. Thank you, Senator Stephan. Are there any bills to be introduced to committee? Yes, Senator Thompson.
Yes, thank you, Madam Chair. I'd want to introduce 24 RS 2291. That is basically the act that we heard last year trying to prevent childhood gender mutilation, gender assignment surgeries for minors, basically.
All right. And is this introduced as a committee bill? Committee, are there any objections to this being a committee bill? Seeing none. Any other bills? Yes, Senator Stephan.
Thank you. I have Bill 24 RS 2189, which has to do with the healthcare fund.
Okay, and that is a committee bill as well?
Correct.
Committee, any objections to this being a committee bill? Senator Petty.
I have no objection. I'm not clear on what is the health fund.
Healthcare stabilization fund.
Okay.
Yeah.
Thank you.
All right, and that one will be introduced in committee, and Mr. Stephan, Senator Stephan, I'll get one of those. Dr. Stephan would have been accurate. Could you give us your other bill if you have one? I think you held up two fingers.
Correct. 24 RS 2196, which is the John D. Springer Patient Bill of Rights.
And we heard a patient bill of rights bill last year, and this is similar to that, only a different bill, correct? Same but different. Committee and objections to this being a committee bill? Seeing none, that has been introduced in committee. Committee members, does anybody else have a bill they want introduced into committee? Seeing none, we will thank you, Senator Stephan, for reminding me that I wanted to do that today. And I got a head nod that we are ready for our presentation. Please come forward and introduce yourself.
Good morning, everyone. I'm Douglas Hill. I am the Kansas Department of Health and Environment. Can you hear me? Okay. I'm the Kansas Department of Health and Environment Palliative Care Program Manager. And I'd just like to say thank you for having allowed the Palliative Care Interdisciplinary Advisory Council and their members to actually present the first Kansas 5-year palliative care state program. And I hope everyone is feeling fine today due to this bad weather that we're having. So excuse my Brooklyn accent. If it happens to come out, I will try to hold it back the best I can, okay? You have the slides? Okay. Today, I will ask, before I actually get started, I just want to give a big kudos and a shout out to our outstanding council that we have. I came aboard in 2020, and we had a council of 12 members at that time, and they have incredible background. They have their own practice, and they are the one who actually spearhead this to get pushed forward. And today I will be joined by Dr. Karen Porter-Williamson out of Kansas City, and Dr. Yana Radovich as well, who's our chair and co-chair. Okay, we're ready to get started. So here we're just going to start with just some general definition of palliative care. Palliative care is comprehensive interdisciplinary care for patients living with serious potential life-threatening or life-limiting conditions with the goal of improving quality of life. That's the big thing right there. We want them to continue their quality of life. It's not end of life, it's them to continue their quality of life. This approach to care prevents and relieves suffering through the early identification, assessment, and treatment of pain and other problems with physical, psychosocial, or spiritual. Palliative care delivered based on needs, not prognosis. Again, it's based on the needs, so diagnosis from the doctor, not prognosis. It is appropriate at any age or any stage of illness and can be delivered along with curative treatment. Next slide, please. Make sure I'm keeping up with you as well. Okay. And again, here, serious illness is defined. Any condition that carries a high risk or mortality or either negatively impacts a person's daily function or quality of life or excessively strains their caregivers. Next slide, please. Okay, just a little background on the council that we have. Like I said, is 13 members on the council. Palliative care experience and their expertise. The Interdisciplinary Advisory Council, consisting of palliative care medical nurses, doctors, social work, pharmacy, and spiritual guidance. We don't have anyone that's pharmacists at this moment on our council, but most of them are palliative care nurses, social workers, and doctors, what we have. Delivery models is in a variety of inpatient and outpatient community setting and with a variety of population, including pediatric and youth and adults. Two of our members are actually board certified hospital palliative medicine. One is Dr. Porter Williamson. She's a chair on our council. And Dr. Brandy Fiesig, she's a palliative care medical doctor out of Stormont. And at least one of our members shall be a patient and caregiver, which is one of our co-chair, which is Donna Yadrich, who would actually be presenting as well. And if you see to the bottom right of the slide here, it actually lists the statute. So we made sure that we stay within the Kansas statute when we actually put together our definition and the needs of palliative care for our citizens in the state of Kansas. Next slide, please. So here, I'm going to just go ahead and just give a quick snapshot of it, and Dr. Porter Williamson will give more detail when we get to the right side of this slide here. Palliative care ensure a value, a strong evidence base is this proving its impact on quality, satisfaction, consumer, and demand and cost. Because it's focused on the highest need and highest cost patient segment, palliative care is essentially a strategy for population health, and palliative care focuses on relieving the symptoms of stress or serious illness. Dr. Porter Whitman, I know she's online right now. She would probably, would like to just go a little bit deeper into the slide on the right side there. Dr. Porter Whitman, are you there?
Sure. Hi. So just having to add that really the importance of palliative care comes through its value. So the value equation is quality divided by cost. Several studies showing that palliative care can improve the numerator in terms of quality of life, decreasing symptom burden, driving high satisfaction and positive patient experiences. And then in the denominator of that value equation, being able to reduce avoidable spending across a variety of settings, whether that's hospital readmissions, outpatient admissions to the hospital from outpatient, hospital and emergency department transfers, and then from home-based services, decreasing total costs as well. So this slide really just highlights the important value that palliative care adds to healthcare.
Thank you. Next slide, please. Okay. Palliative care improve the knowledge and access to palliative care can improve value in can care. So we see 67% of the $4.4 billion in can care is expected for services of beneficiary with serious illnesses, disability and or adult frail. 58.2% is spent for the medical service. We're talking about as for hospital and physician fees. Okay, I'm sorry, I thought somebody had a question. Next slide, please. National workforce shortage shows less than 6,400 hospice and palliative care medicine physicians are in the U.S. One palliative care physician to every 1,200 people living with serious illness. One cardiologist for every 71 persons having a heart attack, and one medical oncologist for every 141 people with newly diagnosed cancer. The increased need for palliative care. Right? 5% of people with highest health needs account for a whole of all expenses. Rising aging population, which is 1 in 5 will be over 65 years by 2030. And today, 25% of rural population are people 65 and older. And advance in healthcare allow more adults and children to live with serious and chronic illnesses. I believe either Dr. Porter Whitson or Donna have some more information they would like to share on this slide here. Hello?
I think we're good, Donna.
We good now? Okay. That's why we're a good team. We're a great team. You know? Right. Kansas work shortage, board and specialty certified. Physician, 21 palliative care, greater than 1,200, 10,500 medical, and 1,700 osteopathic, advanced practice nurses, 13 palliative care, 7,500 to 5,700 nurse practitioners, 1,200 nurse anesthesiologists, 466 clinical nurse specialists, and 100 nurse midwives. Registered nurses, RNs, 49 palliative care, non-pediatric of 50,000. And social workers, there's 3 palliative care of 7,997. The healthcare chaplains data is not really available, but is likely to be limited in Kansas. Next slide, please. Okay, Kansas workforce is continuing as adults in illness or instability, unpaid family caregivers. We're looking at over 340,000 resident unpaid family caregivers, right? And 11.6% of Kansas, nationally is 11.5%. So 4 times licensed Kansas healthcare workers, nearly 7 times the largest healthcare workforce. And registered nurses are equal to 50,000. And 340 million hours of care provided, which is 4.5 billion economic value. Next slide, please. Kansas professional workforce shortage and immediate needs. So we're talking about our needs here. Meager availability of palliative care professionals. Statewide distribution of these providers insinuates workforce shortages. Reliance on palliative care and frontline providers is necessary to meet immediate needs, especially in rural and frontier areas. Again, especially in the rural and frontier areas. Primary care and frontline providers need additional training, education, and access in subspecialty care. Next slide. So here are the 4 areas the council actually worked on to complete the state plan, but the one area we're going to pretty much concentrate on and have more attention will be number 2, which is education and healthcare workforce training. Next slide, please. Okay, Dr. Porter-Williams, would you like to take that?
Sure. So when we think about education, healthcare, workforce training, we really need to be educating on primary palliative care for all disciplines. This was what we're highlighting in the legislative priorities this year with our request to the legislature. Next slide. Doug, do you want me to keep talking?
No, yes, please. I'm sorry.
Okay. All right. So the education and healthcare workforce training recommendations were to increase primary palliative care education in the current workforce for those caring for serious illness, and to increase palliative care in the future workforce caring for those with serious illness. These are the 2 things that we're focusing on this year.
Next slide. Okay. So essential education needs, skill building to primary palliative care, serious illness conversation and communication skill, for example, initiation of palliative care, goals and care, and the education strategy project, palliative care project ECHO, is actually essential for community health and care outcomes. Moving knowledge, not patient. ECHO bring the right knowledge to the right place at the right time. With the case-based specialty medical education, equipping primary clinicians to care for patients in their home community. And research supports ECHO as an effective modality to impact provider and patient outcomes. Next slide, please. So Project ECHO, since 2015, University of Kansas Medical Center have trained over 3,755 frontline doctors, advanced patient clinicians, nurses, social workers, pharmacists, and veterinarians in rural, frontier, and urban settings across the state. 2022 ECHO series on palliative care. So this is what we actually done in the past year and a half. Establish Kansas community of patients to improve lives over people experiencing serious illnesses. We had 200 plus participants across Kansas attend the 4 courses in June 2022. And then we also had another one, pain management for people living with serious illnesses. And we have over 138 participants across Kansas attend the live courses in October of 2022. And over 90% of the attendees reported they would like access to the long-term palliative care education. Next slide. So the request. Establish a mechanism to fund a Project ECHO Palliative Care Center of Excellence for sustainable delivery of primary care education across the state. This is precedented in other states as of Missouri and Texas. A Center of Excellence will allow a committed community of practice of providers to develop these skills over a period of 24 months. Missouri Show Me ECHO, Texas bill, providing Project ECHOs to support our community in addressing child mental health needs when and where it matters most. Medicaid financing model for Project ECHOs, financing Project ECHOs. Option for state medical programs, Medicaid financing for Project ECHO. Strategies for engaging state Medicaid officials, and requiring an annual licensure activity to include a minimum of palliative care education hours. Number two, will create an incentive for health care providers to seek the education by requiring annual licensures, physician, nursing, and social work. CE's activities to designate a portion of existing required hours be focused on pain/symptom management and/or serious illness conversation/communication skills. Next slide. Gratitude for legislative support. Prior to rising palliative care by funding the program by establishing the council, which is the Palliative Care Interdisciplinary Advisory Council. Lending expertise from legislative council colleagues, Senator Gossage and Representative Ellis, and appointing council members to fill position vacancies. Today's opportunity to strengthen our relationship with you to advance access and workforce priorities. Next slide. And that's my presentation on behalf of the council. I don't know if maybe Dr. Porter Williamson or Donna has some additional information they would like to share. Do you have anything at this moment?
I don't.
Okay. Questions?
I'm going to start off with questions, Doug, because I think these are questions that I've asked you before and asked the council that I think might be helpful to the committee. One is, could someone describe the difference between hospice and palliative care?
Dr. Porter, I could do it. I want her to do it.
Of course.
Dr. Porter Williamson?
Sure. So, palliative care is a great big circle of care that's provided for folks who have serious illness in their family while they're still seeking traditional medical services. They want to go in and out of the hospital. They're seeking treatments for whatever conditions that they have. And so there's a much smaller circle that is within the big circle of palliative care delivery. That smaller circle is hospice services. And so that happens when a patient and family come to a point in their illness where they say, I want to use the healthcare system differently now. My goals are focused on comfort in my own natural state. I would rather have a team coming to me and my family to make sure I'm comfortable through the natural dying process, or as that disease takes its natural course, without the in and out of the hospital, all of the testing, all of those sorts of things. And so everyone who's on hospice is receiving a palliative care philosophy of care. But the difference is really how those patients and families are choosing to use our global healthcare system based on their goals of care. Hope that in a nutshell.
Senator Gossage, I wanted to ask Dr. Porter Williamson to expand on your question and explain what are serious illness conversations?
Sure. So when somebody's dealing with serious illness, it's really important that their medical providers are able to communicate about that in a way that helps them to understand what's going on, anticipate what may be coming down the line for them in the future, and really have that information about prognosis so that they can weigh what matters the most to them in the context of where they're at in their illness. And so having this skill to be able to take a patient and family through all of that information sharing and then help them reflect on, based on all of this information, how do I want to approach this based on my personal values, my spiritual beliefs, what's important in our family dynamic. So serious illness conversations really are just not about advanced care planning for the future. It's about grappling with the current scenario so that medical providers are able to make a plan of care that fits with how they want to approach it for their quality of life and for their values and preferences.
Thank you. Quick question, and again, anybody can answer. So if someone is receiving palliative care, Is that covered by insurance, Medicaid, Medicare? Do all of those cover palliative care?
So yeah, palliative care services are for the physician and for advanced practice providers in the hospital or in a clinic-based setting, in a home-based setting. Those are paid for by traditional E&M coding mechanisms. There are important parts of the palliative interdisciplinary team that are not able to bill for their services. So those parts of the team, whether that's especially in the home care setting, where those services that are being provided aren't covered. So in the hospital, the social worker, the nurse, the chaplain are all covered under the kind of the hospital group bill that will be paid for that DRG. But in the home care setting, there's no way to pay those folks. So CNA, if they're needing to go in the home, if there's social work, if there's other nursing support that falls outside of a home health benefit, which is very limited, those elements of the team are not able to be paid for under our usual current mechanisms.
I'm not sure that we made it clear that the council and Doug, you work for and fall under KDHE, correct? So I wanted to make sure that they understood that. And then we mentioned one of the asks of the legislation would be CE credits, like add palliative care as one of the CE credits offering as perhaps mandatory. Could this be done by the Board of Healing Arts because they're the ones who determine CE credit? Does that have to be legislation?
Dr. Porter Williams would know that one.
So yeah, this point is one where we are looking to KDHE to help guide us in terms of what is the best approach. So that's where we're at this point. The hope would be to be able to say of the CE that providers need to get, to not add additional hours, but to say the ability to communicate about serious illness is so important to all medical providers, not just palliative care providers. This is a core skill that medical providers should have because everyone is taking care of people who are so sick. To say, of the CE that you need to get, it would be appropriate to direct a certain number of hours to that skill building, not rather than adding extra hours. The specific approach to that, something that we're continuing to work on with the KDHE research folks.
And my final question, and then we'll open it up to committee, is regarding ECHO, and I know that's kind of a training mechanism, right? And you have used KU's ECHO system to be able to do some training, as you said, with other medical providers. And what is it the ask regarding ECHO?
I'm going to do a little bit, and I believe Donna would probably tap in a little bit on that. What we're trying to do is, as a palliative care program manager, one of my jobs is to ensure that we do two things. One thing is that we have to provide the information to population, and the other is we have to provide the education for our providers. And what the ECHO has been successful is that we actually have what funds we could actually provide to put on a program where we could do at least 4 sessions, and we found that it became very successful, but we have to continue that. The plan is now for 2024 is to hopefully get a palliative care ECHO session going, but if not, if we don't do it every year, to do it at least every other year. And I believe Donna would like to expand on that as well.
Hi, thanks, Doug. Project ECHO's extension for community health outcomes, and it aims to develop a community of practice. So it takes people who are interested in something and experts and works with the actual communities being affected. To develop curricula that is valuable to them, that they feel is realistic and could best help their their situation in their communities. And so we develop a team of, if there's a lot of planning, you develop a team with several primary goals to accomplish. We offer no cost continuing education credit for the disciplines the community planners feel would best benefit from this training. And a center of excellence is where you take a cohort of primary providers in certain communities who agree to do a 24-month education, case-based education of the people in their community, to really develop their skills fully throughout a matter of time, and then become mentors to others through, expansion. So it would be offering no cost continuing education designed by the communities that wanted this intensive education.
Thank you, Donna. And committee, let's open it up to you. Questions. Senator Petty. Oh, I'm sorry, Senator Holscher.
Thank you very much. A little bit of a question in regard to insurance, and I know obviously in your different departments and your work you have to deal with a lot of different insurance companies, and I asked this question. I have a friend who was seeking palliative care for her daughter, and obviously it's a very stressful time when a person is often seeking those services, but then was having problems with getting an insurance approval and the payments. Is there any advice you can offer to us as legislators to help our constituents, or are there efforts happening to help ease through that process?
First, yes, there is efforts being in place right now. We working with some of the teams at KDHE that deal with Medicaid. I can't give you a definite, clear answer on that. I would actually push it over to Dr. Porter Williamson because she is a physician. She probably could give you a little bit more information on that. But there is more information, and I would be kindly to get back with the form here, the council in reference to Medicaid. So Dr. Porter Williamson, I know you got some information on Medicaid, if you would like to expand on that.
I think I could just answer in general about payers, that palliative care services are paid for the same way that the cardiologist is paid for, the same way the infectious disease doctor is paid for. And so when we think about medical necessity, if we are addressing pain, other symptoms, and if we are engaging in goals of care discussions, that there are E&M codes that are associated with those are valid medical services that deserve to get paid for the exact same way that a cardiologist gets paid for, or anyone else. And so I think the important thing is for the insurers to understand that value equation. That it really does come down to that this is really a win-win that aligns what patients and their families need, what providers need in order to provide the care. And when you're providing a medical care that improves value, so improves quality, decreases cost, that should align for there not to be a big fuss about payment.
Great, thank you. And like I said, as a legislator and somebody not so much directly connected to the healthcare profession, sometimes it's just a little bit hard to try to give the right guidance to some of my constituents in that situation. So thank you, Doctor.
Thanks for your question.
And Senator Holscher, I wanted to mention I'm a representative family caregiver on the council. So that is my appointment slot, and it's very important to have the caregiver and patient voice at these councils and making these decisions. Thank you for helping that family.
Other questions, committee? Senator Petty.
Thank you, Madam Chair. You mentioned about the shortage that we have in all the areas of being trained in palliative care. And I was looking at the slide that had a picture of the of the United States. As I looked at it and saw that some of our neighboring states have a larger number of, as at least from this slide, of providers trained. I just wondered if you could expand on what you think is leading that.
Dr. Porter Whipson, I believe she's referring to the Kansas workforce shortage for adults and illness and instability. Can you see that?
I think, is that let's see what that slide is. Is there any way to see that slide?
Slide is about unpaid caregivers.
Yeah, it's about caregivers. It's not healthcare professionals, if that's the one that's talking about the value of caregivers of adults with, and that has a graphical error. It should say with serious illness or disability.
Okay, so this slide does not refer, although it says Kansas workforce shortage.
Family caregivers are vital members of the workforce, even though they're not being paid.
So, again, so how is there a reflection that there seems to be, is there something going on in our surrounding states that's different than Kansas, that there's a reflection of, I guess I don't understand this map. If it's talking about family caregivers. I'm not understanding what this map reflects then. We're not talking about.
The only thing that I can ascertain, and I can look further into it, that's national statistics, is that they have higher population density of serious illness or disability.
Okay, then that. Okay, then I'll move on from that question. Then I'm not sure. That doesn't help me very much on that.
I would definitely get some clarification for you.
Yes.
Right. I was looking at this with the thought that there's something going on in our neighboring states, that maybe it's training or it's funding, that there's better palliative care professional training available. But it doesn't sound like that this is what this slide reflects. If we're just talking about family caregivers. Okay,
it looks like the population of persons with serious illness or disability, but I'm going to look that up while we're speaking.
All right, I have a second question, Madam Chair. And the chair was kind enough to ask the one about the difference between hospice and palliative care. But when you talk about the training and ECHO, and I'm wanting to have it, their annual training, they're not have to pay for it. Currently, when the training that was provided at KU through ECHO since 2015, were those hours, did the nurses or doctors or anybody who wanted to have that palliative care, did they have to pay for their training?
No, we have always, the model Project ECHO is to democratize specialty care education. And so we always try to get funding for the continuing education credits. So there's no cost to the learners.
Okay, so that's always been the model.
Always, yes.
Thank you.
Just to add on to that, what we always do is, what's so good about having, collaborators part of our council, is to actually get funding for operations like this for ECHO. So our caregivers, nurses will not have to actually fork out of their pocket for the training, along with the funds that actually part of the palliative care program that I actually manage now.
Committee, other questions? Yes, Senator Erickson.
Thank you, Madam Chair. Thank you for being here in your presentation. It's very helpful. So one of your requests is to establish a mechanism to fund a Project ECHO Palliative Care Center of Excellence. Do you
Center
have
of Excellence.
Center of Excellence? Do you have a fiscal note or a cost estimate for that?
We do
I see
not.
that, yes.
We do not at this point, and part of that has to do with, from my understanding, from our administration. I also work at KU Medical Center. That the composition of the team depends a lot on the funding, and by the team I mean the specialists, the specialty trainers, like the Dr. Karin Porter Williamsons. You know, are we going to have palliative medicine being you know, at the table training folks? Are we going to have pharmacy? Are we going to have advanced practice nurses? So depending on the specialists at the table and how we get and how their organizations, we try to get representation from all across Kansas. We want community hospitals. We want everybody. So we don't want just one health system to be seen as the expert, because we have experts all over this state. And so based on the mechanism of funding for how they might get compensated for teaching the courses, and then the types of continuing education credits that are offered and the cost of those, we kind of have to understand the makeup of the training, who the specialists are providing the mentoring, and the CE composition before we can really think about costs, specifics.
Thank you. I appreciate that. Follow up, Madam Chair, if I may. Not specific to this, but we know we have a workforce shortage in every area, every industry across the state. And typically when we increase education or license requirements, that tends to increase cost and put up barriers in order to get more people into that. So explain to me how, you know, you say there's a workforce shortage, but increasing education requirements, increasing licensing requirements tends to dampen, you know, the flow or the pipeline going into that field. So can you kind of help me understand the thought behind that?
Dr. Porter Williamson.
I think I would say, you know, and we look to the hope to be able to have a funding mechanism for ECHO that is focused on primary providers in the field. So those are doctors and nurses, social workers, really any element of the interdisciplinary team who would be able to have access to primary palliative care training without them incurring further costs, that sort of thing. The longer term goal is that as palliative care programs develop and that knowledge base is spreading across the state, that there are people who would say, oh, now I have this core set of knowledge and I want my professional development to move in this direction, so that they would be able to seek a certification, you know, from SWIPN. That's the group that does social work certification in palliative care. Or they may say, I'm going to seek a certification, you know, in palliative care nursing. So as folks develop that skill set, there are folks who say, I want to do this work. And so I'm going to seek further professional development. When it comes to the idea of directing, so we're not mandating increasing, you know, licensure certification, but when you provide these educational opportunities, then people realize this is something that they can do and that they can forward their career with. So I don't know if that helps to answer your question. So in relation to the continuing education hours, if people realize that there are programs there that can be a win-win for them, you know I have to get so many CE hours in a year. And if I can say, great, I can do the echo and it will provide me X number of hours for education that I would like to get, that's a win-win for me. Then we're providing them all of the tools that allows them to further their knowledge base and fulfill their CE requirements.
Thank you. Thank you, Madam Chair, for your indulgence. And just one final question. It looks like KU Med School is already integrating this. It would seem to me that this should just be part of medical school training, especially the serious illness conversations. I can't imagine that there's not already training around that in our medical schools. So is that an avenue of going forward, getting the existing medical personnel trained, but then integrating this training, this education, this curricula into medical school?
Yeah, so you're exactly right. We do serious illness training for our, integrated curriculum for medical students, for residents. There are, it's a lot. It's an 8 hour, if you're really going to do it, it's a lot of hours. And so we integrate those types of things into our curriculum. When we're talking about Project Echo, we're talking about the current workforce already on the ground in practice. So this is generations of people who have not had the benefit of these sorts of curricula when they went through training. So we're good at it now. We're doing it now with our current trainees, but there's a whole population of medical providers who didn't have access to this.
Thank you. Yes, Senator Hulscher.
Thank you again. I just wanted to say thank you for your work, for those of you who work in palliative care and your focus on this issue, because obviously it sometimes is a bit of a somber environment, but your work is so very important. And like I said, from the constituents that I deal with, they talk about how wonderful the caregivers are in this area. So I just wanted to say thank you.
Final question, Senator Stephan.
Thank you. I am a bit confused. Help me understand. When we talk about treatment of serious illness or disabilities, doctors, primary care physicians, specialists have obviously been doing that, like you referred, for decades, if not centuries. And you do talk about physicians in your statistics. You're talking about all the shortage of physicians in palliative care, but pain management, disease management, those are all parts of multiple specialties. Cardiologists, pulmonologists, internal medicine, primary care, anesthesiologists do pain management. So are you all telling me that there's a medical scientific knowledge gap in all these in all these specialties that's not being taught, or does this represent more of a new methodology, to a new intensity being brought out into the public, into the home, that's really more of a social service sort of service? Or help me understand that.
Before I turn it over, go ahead, Dr. Porterman. I'm sorry.
Yeah, so that's a great question. Palliative medicine is really an extra layer of support underneath all of those folks, all of those specialties that you've described. And so, when it comes to dealing with serious illness, there are the physical aspects. There's pain and symptom management that is part, of addressing an issue with someone's heart. The cardiology is looking at that. Any of those primary providers are looking at that. The role of palliative care is to serve as an extra layer of support and expertise under those providers for the patient and family, that specifically is addressing how pain and other symptoms, how emotional burden, how financial burden, logistic burden, all of those things play into how they are living with their serious illness. And that is a specific palliative care skill set. The other thing that palliative care does is brings together all of the medical specialties who are helping to take care of that person, because lots of times there are multiple different doctors and services who are involved to be able to mediate what is going on in each organ system and then translate that into what does that mean for the human being who is suffering with that? What does that mean for they and their family now and over time? And so palliative medicine's role is to work with all of those people and to tie together and to really bring back a patient-centered focus so that whatever we're doing in the midst of that very difficult time makes sense to the providers and to the patients and families, whether that's in the ICU, in the hospital, or in the home, or in the clinic.
Thank you all again so much for being here. We're up against our time. Committee, thank you for your questions. And Mr. Neal, thank you for being here. And Dr. Porter Williamson and Donna, we appreciate the insight. Committee tomorrow, some of you know that I had the honor of chairing the IDD committee during the interim. I've asked KDADs to come and talk about the IDD waiver, community waiver, and what's being done to shorten that list. So that will be our presentation tomorrow. Thank you all, and committee, we are adjourned.
Thank you.